From the Journal of Nuclear Cardiology, this is JNC CardioConnect, linking experts, insights, and innovations in nuclear cardiology. Let's dive into the next episode.
Welcome to another episode of JNC CardioConnect, the podcast from the Journal of Nuclear Cardiology. I am Marcelo F. Carli. I'm the Editor-in-Chief of JNC, and I want to introduce a new series. Alongside our regular deep dives into feature papers, we're launching a new monthly series that takes you behind the scenes of each issue. Our goal is simple: to highlight key articles, unpack the science, and give you a quick practical overview of what's shaping the future of our field. We know how busy you are, so we have designed this series to be easy to follow on the go, something to spark your interest, and help you decide what to explore in more depth when you have time. So to kick things off, I'm joined by our early career editorial board members, Cizia Gallegos, Bruno Lima, Dan Huck, Olivier Clerc, and Attila Feher. Each month, they'll walk you through the journal's content in their own voices, starting with the August 2025 issue, and they will share what stood out to them, why it matters, and how it ties into clinical practice or ongoing research. So whether you're a trainee, a practicing cardiologist, or simply looking to stay current, we hope that this new format makes the journal more accessible, more engaging, and relevant to your work. So let's dive in. Dan, why don't you help us summarize the content on this paper from the University of Virginia by Stephen Sharping and Jamieson Burke?
Good morning, Marcelo. The title of this paper is The Prevalence and Prognostic Impact of Additive Abnormal Stress Exercise Markers in Patients with Normal Stress Myocardial Perfusion Imaging. We know from prior research that exercise stress testing parameters provide valuable prognostic information beyond detecting obstructive CAD. And additionally, while most patients undergoing stress imaging in the contemporary era show no signs of ischemia, it doesn't necessarily mean that they're low cardiovascular risk. And so the rationale here is to look at exercise parameters and see if they have particular additive prognostic value in patients who would otherwise be labeled normal or low risk. So their key question was whether the prognostic value of exercise test parameters, such as exercise workload, heart rate response, heart rate recovery, hemodynamic gain index, and blood pressure response, would have additive value in patients with normal spec perfusion and non-ischemic electrocardiograms. And what they found was that in 892 patients in their cohort with normal stress MPI, meaning normal perfusion and no ischemic EKG changes, most had one or more of the abnormal exercise stress parameters that I just mentioned. And additionally, in survival analysis, there was a 36% increase in risk of death or non-fatal myocardial infarction with each additional marker of those exercise parameters. And that was even after adjustment for cardiovascular risk factor. So the take home is that functional capacity measures gained from exercise have substantial and additive value to predict prognosis, even among these patients with normal perfusion that would be labeled normal otherwise. And so patients with poor functional capacity but normal stress testing may benefit from further workup looking into cardiovascular, non-cardiovascular causes of this poor functional capacity. In some cases, especially if there's a high proportion of abnormal functional parameters, there may be MASNC ischemia or multi-vessel involvement that could not be fully appreciated on the perfusion and EKG findings. However, additionally, you also want to look for non-obstructive causes of chest pain, things like coronary microvascular dysfunction, pulmonary issues, and other causes of frailty.
Sounds great. Thank you, Dan. Why don't we dive into this other paper on the automatic quantification of fluid in patients undergoing PET imaging?
Okay, let's do it. Thank you, Marcelo. Very excited to be presenting this paper by Jennifer Renaud and senior author Venk Murthy. The title is Diagnostic Performance of F18 Flurpiridaz PET Myocardial Perfusion Imaging with Total Perfusion Deficit Quantification. The rationale of the study is based on flurpiridaz being an emergent agent recently approved that has more sensitivity than SPECT MPI, but may also allow the expansion of the use of PET technologies just because it doesn't require the on-site cyclotron generators. The total perfusion deficit is a semi-quantitative marker of defect extent and severity derived from sector by sector sampling of relative MPI. Their key question is what is a diagnostic performance of total perfusion deficit or TPD using flurpiridaz PET MPI with a tracer-specific database. And they compare this to visual scores and defect extent values because that has been looked into previous papers from flurpiridaz. From their previous phase 3 trials, they used those PET images and invasive coronary angiography. Those patients were known or suspected with CAD, and they had an angiography within 60 days of the initial PET. They calculated the total perfusion deficit, and they did both global and per-vessel at two different endpoints, defined as obstructive 50% left main or greater than or equal to 70% all three territories, or just 50% LAD, RCA, and circ. For both thresholds of greater than or 70% and greater than 50%, both in the global and per-vessel TPD had similar global performance to visual scoring compared to previous publications with excellent AUC numbers and sensitivity, specificity, and accuracy. And when they did the per-vessel as well, the TPD was very similar. So the take-home message and the clinical implications from this paper was that the automated quantification of TPD with flurpiridaz achieved similar performance over standard visual interpretation and defect extent.
Thank you. Fantastic summary. Just to highlight, automatic quantification is always good to have, but particularly useful for sites that will have no experience in reading PET. The quantification gives you at the elbow help on reading your scan. So I think this evidence is very, very important and reassuring that quantification will help achieve at least similar results to expert reads that were done in the clinical trial. So I think very important for the future development of flurpiridaz in our field. Olivier, why don't we dive into the other related issue to flurpiridaz, which is how do we deal with the residual radioactivity from the rest injection that is impactful both on the visual impression but also on the quantification.
Thank you very much for the invitation to talk about this great manuscript from Carlos and colleagues from multiple US centers. Indeed, as we just heard, we are all excited about flurpiridaz. This is the newest PET radiotracer for myocardial perfusion. It has excellent myocardial extraction properties to quantify blood flow, high diagnostic accuracy, wonderful image quality. But it has one specific characteristic. This is the long half-life of 110 minutes. And this is much longer than the typical half-life of previous PET radiotracers for perfusion, such as rubidium and ammonia. So this is great for regional production and shipping. So you don't need to produce the radiotracer at your site and gives you a bit of flexibility to do the imaging. But if you do back-to-back scanning, rest and stress, you will have high residual activity from the first scan on the second scan. And this is really an issue. It questions the logistics of imaging. So in previous studies, authors have made a break between the rest and stress, 30 minutes, or some people propose you start the next patient and then you bring back the first patient to do the stress, but this is all complicated, suboptimal, bad for patient throughput. And this is why the authors really wanted to know what is the effect of this residual activity from back-to-back scanning with flurpiridaz on the second scan, and whether they could correct it away with a commercially available software. And to do this, they took PET data from 11 participants that had separate scans acquired for 15 minutes, 1 hour apart, and with double activity injected for stress. And then they digitally shifted and combined them as if they had been acquired back to back by taking 8 minutes from the rest and 7 minutes from the stress. And they added the late activity from the rest on the stress. both the distributed activity that was already there and the residual arterial input function that was still able to enter the myocardium. And on this reconstructed scan, they then applied this correction of residual activity from a commercial software and compared to virtual back-to-back scans with and without correction to the separate scans as reference. And the findings are quite impressive. When comparing this back-to-back scan to the reference, they found that on the second scan with stress, the pixel values were increased by 31%, the myocardial blood flow by 64%, and that reduces the sum of stress score by 2.5 points. So this really reduces the effects at stress. This is dangerous. It could hide an ischemia. But the good news is that by applying the corrections, the values were essentially back to the reference levels with differences in pixel value and blood flow less than 1% and a sum stress score that differed only by 0.4. The images were also very closely matching in regression analysis. As limitation, we need to remember that this is a small sample size with some heterogeneous effects across patients, and this digital reconstruction may not perfectly reflect reality. But still, I think the take-home messages are very clear. Those residual effects from a back-to-back flow-period scanning are real. We cannot ignore them. They strongly affect the images, and they can really hide an ischemia. But good news, we can correct this away with commercially available software. And in this condition, it is totally possible to perform back-to-back rest and stress F18 flow-period PET scanning.
Thank you, Olivier. Great summary and a very important new technical development that will facilitate the workflow for introducing flurpiridaz for myocardial perfusion imaging. I think that something that may have also an impact in the field is the fact that we may be able to lower the stress doses. Right now, we require 3 times the rest dose, but if we are making the residual rest injection negligible, we may be able to lower the dose on the stress, which will have an impact not just on radiation dose to the patient, but also on the cost. So there may be opportunities for also making this a little more cost effective. So as you said, it's a small sample. We need more validation of this, but this is very, very encouraging. Bruno, why don't you help us dive into this paper dealing with new therapies for cardiac sarcoidosis?
Thank you so much, Dr. Carli. And I'm going to discuss this manuscript by Louise Crowley and colleagues from the University of Birmingham at the UK. And this is an important study because we know cardiac sarcoidosis is tough to manage, and many patients don't respond well enough to standard steroids. So we're always looking for alternative treatments, and infliximab has emerged as an option, but solid evidence about how effective it truly is, especially measured through quantitative imaging, has been very scarce. So the key question of this study was, can serial PET imaging using quantitative measurements clearly show us whether infliximab helps patients who haven't responded to steroids? And the study found promising results. It was a small group of only 12 patients that were treated by infliximab, but PET imaging showed significant improvement. There was a clear reduction in myocardial inflammation, specifically key PET markers like LV maximal standardized uptake value, or as we call it, SUV max, and cardiac metabolic activity, known as CMA, improved notably after around 5 months of therapy. And interestingly, these benefits seem durable. So patients who continue therapy still show good results even at 2 years. Another crucial insight was that visual assessments of PET scans didn't always match quantitative measures. So the quantitative methods prove much more accurate in reflecting actual disease status. So the clinical takeaway here is that infliximab could be a valuable treatment for patients with cardiac sarcoidosis who aren't responding well to steroids. And from a practical standpoint, this study underscores the importance of quantitative PET imaging. Rather than just looking visually using specific quantitative metrics, again, seems essential for accurately tracking inflammation and guiding treatment decisions. But importantly, to fully confirm infliximab's benefits and refine imaging techniques, we definitely need more prospective trials moving forward.
Fantastic, Bruno. Thank you very much. One additional thing that I think is a highlight is the fact that the efficacy of novel therapies in the field of myocardial inflammation will be very hard to do on large-scale trials, and imaging surrogates will actually play an important role in defining efficacy. And as you well highlighted, metabolic imaging with PET is becoming a key driver not only of management decisions on when to start and when to stop immunosuppression, but also, as highlighted in this paper, to begin to define the efficacy of new treatments for this disease. Attila, walk us through the paper on the technical details on how to assess adequacy of the time activity curves and what the impact that might have on the quantification of myocardial blood flow.
Good morning, everyone. I'm very excited to present this paper by Hidesato Fujito and Piotr Slomka from the Cedars-Sinai group. The title of the paper is 82 rubidium positron emission tomography, myocardial blood flow quantification, influence of arterial input curve quality on diagnostic accuracy. The basis of the paper is that PET myocardial perfusion imaging is getting increasingly more available to everyone with reimbursement for myocardial blood flow quantification. And we know from prior research that high quality arterial input function curves are really essential to accurately quantify myocardial blood flow. What this paper really looked at it is whether the shape of these arterial input curves affect the diagnostic performance of myocardial blood flow, rubidium PET. And in order to investigate this, the authors gathered data from 386 patients without prior coronary artery disease who underwent both rubidium PET and invasive coronary angiography within 6 months. When they looked at these PET perfusion imaging studies, they identified different features for the stress blood pool time activity curves. The first one was low stress rest peak ratio. So they looked at the magnitude of the input activity and divided stress by rest and looked at the ratio for stress over rest. The second one was slow activity rise and slow activity decline. Fourth one was broad peak, and the last one was multiple peaks, where multiple peaks are present. Patient characteristics, that the average age was 71 years. It was quite a sick population, with 61% having obstructive coronary artery disease on invasive angiography. And what they found is that the shape actually mattered in terms of diagnostic performance, specifically the low stress over rest peak ratio and the slow activity rise was associated with lower diagnostic performance. So this overall suggests that the shape of these stress myocardial blood flow arterial input function curves may have a significant impact on diagnostic accuracy in these patients.
So paying attention to the shape of the time activity curves, particularly the arterial input function, makes a huge difference, as you summarize very well on these papers. So for those of you who are beginning to use quantification, I encourage you to actually dive into this paper and try to understand the implications of the time activity curve shape as you begin to do quantification. So a big thank to all of you for your incredibly thoughtful insights and really engaging summaries of the content of our August issue. And for our audience, we hope that this new series will bring you timely, relevant evidence that supports best practice. That's a big goal of JNC. And also that showcases, as we've done in this issue, the constant innovation that's driving our field forward. So thank you all for listening, and we hope you'll join us next month for our JNC CardioConnect.